Hi, I'm Andrew Penn. I'm a psychiatric nurse practitioner and an associate clinical professor at UCSF in the School of Nursing. I'm going to be talking about what nursing can bring to the conversation about psychedelic therapy today. And by way of disclosure, I have worked as a study therapist on the MAPS-sponsored MDMA study for PTSD, and I'm currently a co-investigator on the USONA-sponsored study of psilocybin facilitated treatment for depression. Obviously, because these are not FDA approved drugs, these are all off-label treatments at this point, and any conversation I have about patients will be obscured for privacy. Just as a sort of an overview note about this presentation, this is not a data-driven presentation. This is much more of a theoretical, conceptual presentation. So there will not be a lot of graphs and outcomes and methods and such in here, because really what I want to do is I want to introduce the both the qualitative and the nursing aspects of psychedelic therapy going forward. And as such, because I'm trained as a nurse, I will be using the term nurse and therapist interchangeably. I don't think that these are things that are exclusive to nursing, but I do think that these are things that nursing can inform our colleagues about in doing psychedelic therapy. So I'm going to talk about moving from a pathology-centered approach to a care-centered approach to psychedelic therapy, and talk about a model that I've begun to write about with some colleagues using what's known as a Caritas model of human caring science, and talk about how psychedelic therapy and nursing are really very well aligned. So our colleague Matt Johnson at Hopkins made this tweet recently, which I thought was really fabulous. He said, psychedelic therapy is more psychotherapy than most pharma companies, and I would add, and psychopharmacologists and neuroscientists know how to deal with, and more pharmacology than most psychotherapists know how to deal with. And I thought that was a fascinating concept, because really, when we've looked at some of these psychedelic therapies, there's been a little bit of this black box model here. And so we haven't always described what's happening in the environment of care. This is really kind of an artifact of biological psychiatry, where we say, we put this drug in to this person who had this condition, and out on the other side came this change, whether that's a shift on a standard rating scale or what have you. But looking at the specifics of what is happening in the experience of care is what I was interested in as a nurse. So traditionally in Western medicine, if you will, we look at this sort of pathology-centered care. There's a disease that happens to reside inside of a person, and the person really is kind of decentered. They're removed from the larger field of their existence, the people that love them, their story, the essence of who they are as a person, and that can get lost sometimes in this sometimes heroic but myopic attempt to cure a disease. So the disease becomes the center of attention. And this traditionally has been somewhat of the worldview of medicine, but increasingly I see this happening in nursing, especially as nursing becomes more technologically focused. The disease becomes very centered. And we might call this curative care, and that's certainly not a critique, it's just an observation. But the challenge, one of the outgrowths of pathology-centered care, is that we start seeing pain and suffering as one and the same. And really, if you take that idea that pain is the non-negotiable portion of your experience, but that suffering is how we respond to it. It's do we try and run away from the pain, or do we become so attached to the pain that we can't have any other experiences? Now, the obvious attempt to address this would be what we might call lytic treatments. So this comes from microbiology. We take a drug, we poke a hole in the germ cell, and it dies. And so we've extended this metaphor to psychiatry. We talk about anxiolytic medications that somehow are going to poke a hole in the experience of, say, anxiety, and away goes pain, away goes suffering. And I don't think I need to tell most people in this room how well that has worked. Not terribly well. And so I often think about psychiatry as being inherently palliative. And sometimes palliation is used almost like a consolation prize. We can't do anything else for you, but we'll connect you with palliative care. And I think I'm speaking to the choir here, but I think I find that kind of offensive. And I think about psychiatry as being kind of inherently palliative because it's pretty rare that we cure things. And maybe that's okay. Maybe we help people live their best lives in spite of their illness, and that's okay. That we can care for a patient even if we can't cure them. So where does nursing come into this? So the experience of human caring, which I think nursing embodies, is often ineffable, it's implied, it's expected. And as such, sort of like the air that we breathe, we only notice it when it's not there. And if we don't talk about what's there, if we don't see it, then we can't study it. And some of this may be, I can take a feminist discourse on this and say, this is because nursing historically and caring has often been the work of women, and that work has been undervalued. But that's probably a whole nother conversation. But, when we don't get good care when we're in the hospital or sick, we definitely notice its absence. But when we get good care, we often have a hard time sort of describing it. And I think about nursing taking an approach on human maladies that you would call a person who happens to have a disease approach. And in this mindset, the disease is just one small part of a wide open field of that person's existence. In this worldview, the patient and not the disease is what's centered. And in this view, there's room for family, there's room for love, for work, for this sort of whole story of our lives, in addition to the presence of a disease. Doctors and nurses are still part of this landscape, but they're more peripheral. And there may be curative efforts that are going on, but they're not the center of attention. But they play this important supporting role. So this is what my colleague Jean Watson would call a curative approach, and as just a point of contrast to curative care. And the psychedelic therapy model, I think, has probably been pretty well discussed in these sessions, so I won't belabor what this looks like. But this bookending of the drug session with psychotherapy, both in preparation and following in integration afterwards. And the more I thought about this process, the more I thought about it as helping a natural process of healing to occur. And you could liken this to nurse midwifery, in which a baby being born is not a medical event. It's not a pathological event. It's a natural human process, which sometimes gets stuck and sometimes needs a little help. And a nurse midwife helps this natural process unfold. Another metaphor I thought about is it's like the intensive caring unit, if you will. Those of us who are nurses or who have worked in an ICU for 12 hours with somebody in a non-ordinary state of consciousness, really that shouldn't be an unusual experience, the idea of sitting for 8 hours for somebody undergoing, say, psilocybin treatment. And this is not a new idea. So I found this fantastic article about a nurse in Canada, because this idea that of women being medicine carriers has been around since antiquity. I think about people such as Maria Sabina or the priestess oracle at Delphi. So the idea of women being the carriers of this, and by extension, I say women largely comprising the profession of nursing. So this was Kay Parley. She was a nurse in Canada, in Saskatchewan, Canada, working with Humphrey Osmond in the late 1950s, treating people with alcohol use disorder, and wrote this phenomenal article in the 1964 American Journal of Nursing called Supporting the Patient on LSD Day, with these wonderful quotes where she talks about things like the nurse-patient relationship during LSD treatment is, I suspect, like that between partners on a mountain climbing team, warm, cooperative, intimate, and yet objective. And amazingly, Kay Parley is still alive. She is 98 years old now and living in Regina, Canada. And in 2016, wrote a fantastic memoir called Into the Mental, which I highly recommend because she has a phenomenal story herself. So other people have tried to define what a psychedelic guide might need. Now, Timothy Leary probably has one of the more poetic ones, saying that this profession would need to be as patient as a first grade teacher, as humble and wise as a Hindu guru, have the loving dedication of a minister priest, the sensitivity of a poet, and the imagination of a science fiction writer. So that's pretty poetic, which I would expect from Tim Leary. Now, my colleague Janice Phelps has articulated this in a perhaps less poetic but more actionable paper called Qualities of a Psychedelic Therapist, where she talks about things such as empathic abiding presence, enhancing trust, having spiritual intelligence, knowing what these drugs do both psychologically and physically, having self-awareness and ethics as a therapist, and being proficient in complementary techniques. So I took Janice's ideas and I worked with Gene Watson's ideas. So Gene Watson is well known within the realm of nursing, and I should be well known in other fields as well. But she got me thinking about, how do we show up for patients in psychedelic therapy? How do we care for them? And what's the experience of the person who is being cared for and is caring for the person undergoing psychedelic therapy? So, this is really what brought me back to my nursing training. And Gene Watson has been talking about this for 40, 45 years, really trying to describe that ineffable experience of care that the patient undergoing any kind of nursing care experiences, and how that experience is co-created between the nurse and the patient. So I wanted to marry these two ideas, the psychedelic assisted therapy and Caritas nursing, into something that I would call psychedelic Caritas nursing. And the idea being this. So we come back to this original idea that we are treating a patient who is experiencing pain, and I'll define that very broadly. And that could be the pain of a life-ending diagnosis, or the pain of early life trauma. And so that idea that suffering is, we have some say in how we suffer. We may not be able to have say in the pain that we experience, but could this experience of psychedelic Caritas nursing create more space between that nucleus of the pain and this orbital, if you will, of suffering, so that there's more room there for the whole experience of life? What they called in Zorba the Greek, the whole catastrophe, right? Because really, I think those of us who've worked in psychiatry, those of us who worked in palliative care, know that this suffering exists in the story that we tell ourselves, that we tell other people about our lives. I just had the unfortunate experience of going to virtually a funeral of a family member overseas, and realizing that, the story that is told about us at the end of our lives often describes this suffering and how we dealt with it. And so a lot of the story is what we tell ourselves as well. So this came to be into a paper that was just published a couple of weeks ago with great help from our colleague and fellow presenter, Tony Bossas, and the three of us, including my colleague, Billy Rosa in New York, who's a very well-known palliative care nurse. We created this model, which I'd like to share with you today, that I'm thinking of as Caritas, psychedelic Caritas nursing. And there's a lot of talk right now in the psychedelic world of what kind of therapy are we doing in these psychedelic therapy sessions. For a long time, it was really sort of very poorly defined, kind of inner-directed, non-specific, and more specific models have started to evolve, including internal family systems, ACT, cognitive processing therapy, and then some somatic treatments such as somatic experiencing. And I think of this as really being kind of an umbrella over any type of therapy that somebody wants to do. So this is really complementary to any therapy model, because this is really about, how do we show up for our patients? How do we engage with our patients? And this can inform the treatment model that we're using. So psychedelic Caritas nursing really, broadly defined, there's sort of two big silos you can think about. One is the way we tend to the patient, and the other is the way that we tend to ourselves and to the world at large. And I'll get into these more specifically as I go forward, but really it starts with trust. It goes on to develop a teaching and learning experience within that caring relationship where we're attending to the whole person. We're supporting them authentically, no matter what comes up. We receive it with equanimity and loving kindness, and that we can be creative in this process in the way that we engage with our patients. And that in order to do this, we have to have some sense of our own spiritual awareness, or at least our own self-awareness, and that so that we can attend to whatever comes up for the patient, particularly those that might be spiritual or mysterious, that we create a healing environment at all levels, and that we administer these sacred acts of caring, such as something as simple as helping somebody get to the bathroom. So these concepts come from Jean Watson's work. So this is central to what she has created. These are her 10 Caritas processes, which I'll now talk about how we're going to apply those to psychedelic therapy. Another metaphor I think about in psychedelic therapy is really co-creating between the patient and the therapist, or the patient and the nurse, creating this sort of house of healing together. That this is really kind of a remodeling project where the therapist is both a collaborator and the contractor. So they're helping to do the work, but they're helping the patient imagine how their life could be different. And we talk about this container in preparatory work with psychedelics, talking about how it has a psychological aspect. We know what the patient's story is. We know what challenges may come up for them. There's a physical, safe setting, and there's a relationship aspect. Now, remodeling, if you've ever done it, can be challenging. So this was my kitchen when I first moved into where I live now. Very vintage 1985 vernacular architecture, not the most attractive place, and it was pretty much falling apart. This is what it looks like now. Now, to get from here to there, it was kind of messy, and we lived in our apartment as we tore this place up. Now, there's no way that I could have done this myself. In order to do this, we needed a guide. So this is Pascal, our contractor. Couldn't have done it without him, but he came in and he didn't say, oh, this is what I'm going to do. He said, what would you like? And looked at the space and imagined it differently in ways that maybe I couldn't have done on my own. So now a lot of people imagine psychedelic therapy to be this kind of quick fix, and the media has certainly contributed to this where, you have one treatment and you're all better. And the reality is that sometimes psychedelic therapy can be kind of messy in that, people are asked to do challenging things, to look at painful aspects of their lives, but out of that may come a measure of relief. Now, there's been some talk of, can we make this more efficient by maybe doing this through an app or even artificial intelligence? And I would posit that this is a deeply human process. So technology may have a role in this, but I don't think it's going to be a central one. So going back to this idea of having somebody who's going to help us along this process, we can start to apply some of these concepts that I described earlier to the idea of rebuilding our house. So just run with this with me. So in order to allow somebody to work on your house, you have to trust them. And they're only going to stay for a short period of time. So this is a short-term relationship, but one that has to be based on trust. And part of the way that we develop this trust is that we begin to learn from each other. So the contractor needs to learn how we live in our house and help us create a home that is going to be most optimal to how we want to live in it. And this trust also, of course, applies to the therapeutic relationship. Now, Florence Nightingale talked about this 150 years ago when she talked about 160 years ago now, when she talked about how really we as care providers, we create the environment for healing to occur, but it's really a natural process that happens, and we create this sort of optimum condition for healing to occur. And Annie Mithofer, who's a very well-known therapist in the MDMA world, talks about this same idea of an inner healing intelligence that really does the healing, and that what we do as providers is we optimize the conditions for that healing to occur. Now, what does this look like in therapy for patients? So I've taken these quotes from the NYU study of psilocybin that I was very kindly shared with by Alex Belser and Cody Swift, who shared their qualitative research with me. And patients talked about things like feeling protected, and that allowed them to open up to this experience. That they experience trust by being listened to, and that these statements that were noted and offered back to the patient at a later point, which really engendered a sense of that they were being understood and that they could trust the people that were with them. So once that trust is established, and we've done that through not only listening and showing up, but also by our impeccable behavior, that we are highly ethical. We can then enter the frame of the subject, of the patient, what we might call intersubjectivity, and really begin to see how they see the world. And the patient sees how we see them. And so as we become more comfortable with each other, then we can start to get creative in how we teach and we learn from each other. So we have to first understand how that person lives in their house before we can help them rebuild it. And this is, like I said earlier, a collaboration. By watching how that person resides in their home, we can understand how to make it better for them, how to help them make it better for themselves. And before we can start tearing down walls, we got to understand what's there. Because as we know, if you've ever remodeled a house, some houses are really simple. And then others, you find all sorts of things buried in the basement or in the wall boards when you start taking things apart. So we want to have some sense of what might be in there. But really, we're embodying this idea that the philosopher Martin Buber introduced of the difference between an I-it relationship, which is where I, the therapist, as the nurse, am observing you as an object. Right? That's the experience of feeling objectified. That we transition from that to really one of an I-thou relationship, and we call this intersubjectivity. Right. In the Caritas nursing model, this is this idea of authentic presence that supports the inner world of the patient. And that trusting, healing relationship is really central to this. So how did patients experience this? Well, they talked about how you are sensitive to everything in that state. And that everything really matters. The choice of your words, your actions, the way that you hold yourself as the nurse, as the therapist, is critical in this state because of the sensitivity of the patient. And also the capacity for the therapist to note things about the patient's behavior. In this particular subject, they talked about how every time they talked about their breast cancer, they would touch their breast where the cancer had been. And the therapist made a very insightful observation of that, which led the patient to realize maybe it's almost like I'm trying to rub the cancer away. Now, psychedelic experiences can be challenging, even in a therapeutic context, maybe even more so in a therapeutic context. So we, as a nurse, as a therapist, must stay present no matter what happens. So the question that I have is, how do we embody this idea of loving kindness? How is empathy conveyed? How do we have what Janice Phelps would call an empathic abiding presence? And I think about this idea in Buddhism as of a bodhisattva, somebody who is present to all feelings for another person that arise during that session. And a lot of times this requires a kind of stillness, and which is hard for some of us. This is having been a therapist in these kind of settings. It's you do a lot of sitting still, a lot of holding space, and that's important. Because a lot of times we will find ourselves as therapists, and I think patients, we all find this as humans, that we want to avoid suffering. And so during COVID, like many other people, we got ourselves a dog, and lovely little dog, but he sure does like to bite sometimes. And the interesting thing about being bitten by a dog is that your natural inclination is to want to pull your hand away, which totally makes sense. But the way you get your hand out of a dog's mouth is you actually push in. You go further into the scary thing. And when you do that, the teeth open up and the jaw opens up and you can get your hand out of the teeth. But for many of our patients who've spent a lot of their lives avoiding what they're feeling, there's this tendency not to want to go in, but to want to pull away. And oftentimes a psychedelic experience can really amplify the intensity of that fear, and that people need guidance to help them stay with that fear. Now, sometimes the music in the therapy session can be used as a kind of current that helps the person get from point A to point B. And this is a useful tool to remember that we have at our disposal. So what should we be doing during the psychedelic session? And this is the strange paradox, right? We are attentive, which is a very active process, but we're often not doing as much as it might seem. There's this idea in Taoism of Wu Wei, of doing, not doing. And this might take the form of holding expectations lightly, but being open to things coming up that we weren't expecting, that we're not holding that agenda so rigidly that other things cannot emerge. And that often that really, less is sometimes more here. And again, this is an idea that that Nightingale talked about in 1860. She essentially said, look, people come in and they try and make people feel better when they're sick by talking at them. And often it backfires. It makes them feel worse. And that really what a lot of times people want is that space to be held. But really the chattering hopes, as she called it, were really often to make the person who is trying to help feel better about themselves. And it really actually makes the patient feel worse. I was taught this in psychedelic therapy training of this acronym of WAIT, which is why am I talking? So if I find myself talking to the patient or talking at the patient, which is worse, I sometimes will say, wait a second, what am I adding anything to the conversation that would be better than silence? Because oftentimes silence is a much better response. And what happens when we have that silence? What happens when we have that spaciousness? Is it possible that we could have other possibilities emerge? If we did, what might emerge? Pablo Neruda has this beautiful poem called Keeping Still, where he has this line. He says, if we were not so single-minded about keeping our lives moving and for once could do nothing, perhaps a huge silence might interrupt this sadness of never understanding ourselves and threatening ourselves with death. I think one of the things that often emerges in psychedelic sessions is grief. We spend a tremendous amount of our ego energy holding back feelings of grief. And that grief can take many different forms. I'll talk about that in a second. And when that ego is relaxed by a psychedelic, this grief can come pouring forth. And the grief can be personal from our own life experience, but it can also be ancestral. It can be things that we have been carrying around from our families that maybe happened before we were even born. Francis Weller, who's a wonderfully lyrical writer in the Bay Area, talks about the five gates of grief. And by these, he means things like the obvious, that everything we love, we will lose, but these more subtle forms of grief, like we grieve the things that have not been cared for us. We grieve the sorrows that are in the world, and Lord knows those have been plentiful in the last several years. And we grieve the things that we hoped for, but we didn't get in our lives. And that finally, like I said earlier, we carry this ancestral grief. I really recommend his book, The Wild Edge of Sorrow, as a beautiful lyrical map of these kinds of griefs. So how did grief occur for patients in this study, and how was it received with loving kindness and presence? In this particular quote, the subject talked about the suddenness through which the cancer changed them there, and how everything changed differently, and how just having that understanding of what they were going through from the therapist was tremendously important. And Kay Parley, who was the nurse therapist from the late 1950s, talked about how you are really the tether. You, the therapist, are the tether to that patient and their sense of direction. You are going to be there for them the whole time, and that you hold that space with a kind of intuition and empathy. Now, for some people, psychedelic experiences are very spiritual. And the question becomes, how does the spiritual practice, or what Janice Phelps calls the spiritual intelligence of the therapist, affect that relationship with suffering? And does that experience of being witnessed, just witnessed, does that help to alleviate suffering? And how do we help, from an existential standpoint, patients find meaning in that suffering? What did that look like from patients? Well, it talked about how that sense of understanding could be conveyed even without having to say anything aloud. That the therapist, just the presence of the therapist, conveyed that, yes, I have a sense of what you are experiencing right now as the patient. And that we meet our patients in this very kind of daily kind of way, that we are all humans going through this experience of being alive together. And I think about what Ram Dass said, we're all just walking each other home. And this was conveyed in this particular quote. And is it healing for us to allow ourselves to be cared for by another person? So these are my colleagues in Colorado working on the MAP study, and the gentleman on the right is Bruce Poulter, who is also a nurse. And thinking about things as simple as taking somebody's blood pressure, as we do in these studies, but something as daily as going to the toilet. This is something we have to help people get to the bathroom in psychedelic sessions, because you're there for 8 hours. You got to go to the bathroom. You got to help people there. And this is a kind of a personal thing, right? But as a nurse, I'm not bothered by helping somebody to the bathroom. I've done it hundreds of times. How was it for the patients, though? Was this weird? Was this difficult? And part of this sense of safety of having your human needs cared for was conveyed in the preparation, that the person could go in feeling completely safe and allow themselves to trust and let go in that process. And this was a subject who talked about going to the bathroom with one of the study therapists, and how that would normally be very strange, but it was like, I trusted this person, so I could allow that to occur. Phelps also talks about understanding how the psychedelic medicines affect the body, and also creating this environment for healing. So this is our study room at UCSF, or at least what it used to look like. You can tell it's sort of a living room. I call it the funky Airbnb. And making this safe environment for patients. And of course, this is not a new idea. This is something that goes back to the ancient Greeks, the Hygeia, the goddess of the healing environment. And Nightingale also talked about this in her environmental theory of nursing, that the point of the environment is to assist the patient in their recovery, and that the nurse is part of that environment. Leary, of course, talked about this also, talking about the famous concept of set and setting, which I won't belabor here because I'm sure most of you are quite familiar with that. But I think about this, how do we, and we're talking about in palliative care here, how do we move from this way that we often die in this country to what B.J. Miller, who I have a lot of admiration for, talks about, going from an anesthetic approach to an aesthetic approach? Can we begin to appreciate the beauty of the world around us, even in our last moments of life? And I thought about that scene in Soylent Green, where the character Saul goes off to die, and he's sort of surrounded by these projections of fields of flowers, and this sort of dystopian future of what dying might look like. But then I started thinking about modern day hospices. I'm sure these are probably places that many people in the audience have seen rooms that look like this. I think the one on the left is Zen Hospice here in San Francisco. These beautiful home-like environments where people can spend their last days of life. But I thought about, gosh, I love being outside. If I could be comfortable, I think if I had a choice, I'd want to die outside. These are pictures from the Spanish flu, which looks pretty miserable. But I thought, what if we expanded our imagination and we created spaces in hospice where people could be comfortable outside with an open sky as they drew their last breaths, assuming that they were warm and safe and comfortable. Why not? And that experience of care is really important in psychedelic therapy. Patients have a kind of transference to the space. It really has that feeling. And if you've ever been in long-term therapy, you kind of develop a sort of affection for the space, the couch, the cushions, the artwork on the walls. And patients had that same kind of experience as well. And then finally, we move to integration. And so integration, coming back to the metaphor of remodeling our house, it might be kind of thinking of this as a rearranging of the furniture, or moving features of the house around. The basic structure remains the same, but now there's a whole different perspective on where they live. And the house they've lived in for a long time now feels new. And sometimes I think part of therapy is just cleaning the windows so you can see what's been outside all along, but you've been unable to see it because your windows are dirty. And therapy allows us to see what is right before us. And for many people in integration therapy and psychedelics work, it's not anything new has occurred. It's that they can see the world afresh. I think Proust talked about that is the real adventure in life, is not discovering new lands, but being able to see that which has always been there with fresh eyes. So the poet David Whyte, I'm a big fan of, noted that half of life is mediated by that which is disappearing, and the other 50% is that which is emerging, and that we stand on this frontier between these 2 points. And often an important psychedelic experience draws a really bright line around this moment, this place where that frontier where we sit between that which is going away and that which is emerging. And this moment of stillness is really an opportunity. Irving Yalom talks about sometimes he will take a piece of paper and draw a line along the horizontal axis, and the left side says birth and the right side says death. And he'll hand the paper to the patient and say, mark a line, where are you now? And obviously in palliative care, we're probably going to be a lot further to the right than we are to the left. But regardless, we have this moment of reappraisal, of appreciating where we are and where we want to go next. So when this building process, or rebuilding process, if you will, has reached a natural completion, and I don't know if it ever truly ends, we may find ourselves living in that same house, but now it's different. It's reimagined, it's brighter, it's more spacious. We may actually find that we enjoy living in it. And perhaps we never really appreciated how beautiful the house was. But now that it's been changed, now that it's how we want it to be, we want to invite others to visit because we want them to come inside. There's a warmth there. Home is sacred. So I want to end with a poem also from David Whyte. This is called The House of Belonging. He said, I awoke this morning in the gold light, turning this way and that, thinking for a moment, it was one day like any other, but the veil had gone from my darkened heart, and I thought, it must have been the quiet candlelight that filled the room. It must have been the first easy rhythm with which I breathed myself to sleep. It must have been the prayer I said, speaking to the otherness of the night. And I thought, this is the good day you could meet your love. This is the black day someone close to you could die. This is the day you realize how easily the thread is broken between this world and the next. And I found myself sitting up in the quiet pathway of light, the tawny, close-grained cedar burning round me like fire, and all the angels of this housely heaven ascending through the first roof of light the sun has made. This is the bright home in which I live. This is where I ask my friends to come. This is where I want to love all the things it has taken me so long to learn to love. This is the temple of my adult aloneness, and I belong to that aloneness as I belong to my life. There is no house like the house of belonging. And with that, I'd like to close and thank you for your attention. And I hope you'll stick around for the panel at the end of the day, where I'd be happy to take your questions. Thank you.